Hello, Psyche community, and welcome to our presentation, Impact of COVID-19 Across the Lifespan, Older Adults. I am Beth DiNapoli, Medical Science Liaison for Otsuka Pharmaceutical Development and Commercialization, Inc. I'll be serving as the moderator, and Dr. George Alexopoulos will be our topic expert for today's exciting discussion. I'm excited to introduce you to our esteemed speaker, Dr. George Alexopoulos. Dr. Alexopoulos has published more than 350 articles and book chapters on the psychobiology of geriatric mood disorders and on effectiveness in services research. He founded the Weill Cornell Institute of Geriatric Psychiatry in 1994 and still serves as its director. Dr. Alexopoulos is also the director of the NIMH-supported Advanced Center for Interventions and Services Research in Late Life Depression. He is the S.P. Tobin and A.M. Cooper Professor at Weill Cornell Medicine, Professor of the Graduate School of Medical Sciences, and Vice Chairman of Geriatric Psychiatry. He has served on the Board of Scientific Counselors of the National Institute of Mental Health and several other organizations. Lastly, Dr. Alexopoulos has been the editor for Western Hemisphere and Japan of the International Journal of Geriatric Psychiatry for over 20 years and is on the editorial board of several other professional journals. Thank you so much for joining me today, Dr. Alexopoulos.
Thank you.
Before we begin, I just want to remind the listeners that this presentation is sponsored by Otsuka Pharmaceutical Development and Commercialization, Inc. and Lundbeck LLC, committed supporters of the mental health treatment community. I'm a paid employee of, and our speaker is a paid consultant to OPDC. Just as a disclaimer, if you or someone you know is in crisis, please call the Suicide Prevention Hotline, Lifeline at 1-800-273-TALK-8255 or text the crisis text line at 741-741. Now, I wanted to begin by just talking about COVID-19. We know that it's affected millions of individuals, but the older adult population has been particularly affected or impacted in terms of catching the illness and suffering its consequences, including greater mortality and morbidity rates. The CDC reported that older adults are more likely to get COVID-19 infection and have worse outcomes compared to the general population. You can see some of the statistics below. Older adults made up 31% of COVID-19 infections, 45% of hospitalizations, 53% of intensive care unit admissions, and 80% of deaths caused by this infection. Another thing to be mindful of is that COVID-19 may have an atypical presentation among older adults, with altered mental status being an initial presenting symptom in the absence of respiratory or even that fever symptom that many experience. And we'll get into that a little bit later. But the focus of our presentation is really the impact that COVID-19 has had on mental health of older adults. And what's really interesting, when I did my initial dig of the literature, what I found was that in the earlier stages of the pandemic, older adults appeared to have an optimistic outlook. And this was highlighted in two separate studies. The first study conducted an assessment, and it was done in March of 2020. It was a nationally representative adult sample. And what they found is that older age was associated with perceived less risk of getting COVID, getting quarantined, and running out of money. It was also associated with perceived larger risk of dying if getting COVID, and less depression and anxiety. A separate study, which conducted qualitative interviews during that first 2 months of the pandemic with older adults, and this was with older adults that had pre-existing major depressive disorder, they found that older adults showed some resilience during this time, but they did have concerns about the future. Depression, anxiety, and suicidal ideation symptom scores did not differ from the scores before the pandemic. And they uncovered 5 different themes that they highlighted there on the right of the slide. So I'd love to turn it over to you, Dr. Alexopoulos. Are you kind of surprised by these findings? And why do you think older adults were so resilient or optimistic during the beginning of the pandemic?
Thank you for the question. In fact, I'm hardly surprised. Older adults have a variety of advantages over younger adults that are often overlooked because we always see them as vulnerable and unable to deal with stress. In reality, older adults have experienced stressors throughout their lives, and they learned that the overwhelming emotional responses to stress that teenagers and younger adults have essentially evaporate quickly. And they have been desensitized to their own emotional distress. So that in itself led to the development of coping skills when presented with stress. A second reason for which I believe older adults are less affected by the social isolation of the pandemic crisis is that it may be explained by the social emotional selectivity theory. That theory was advanced by Charles and Carterson, and it suggests that although older adults have a reduction in their social network because their friends die and move away and their children move away and so on, older adults develop greater satisfaction by investing in fewer but more valued social relationships. So although they have a somewhat smaller network, they treasure that network and they derive comfort and pleasure out of that network. So when you speak about social isolation, that overall in the older population, it doesn't mean that they would cut themselves completely from the world, but they would maintain relationships with those that they value most.
Yeah, and I think that was one of the themes that they highlighted there, that most didn't feel socially isolated, that they were still maintaining those contacts with people that they really valued. And I think on the next slide, a lot of what you talk about with the socio-emotional selectivity theory relates to a lot of these statistics too, that even though rates of mental health symptoms during COVID-19 tended to be lower than that found in younger adults, the pandemic still has negative impact on mental health of older adults. So you can see, for example, there was increased emotional distress and avoidance behaviors during this time. Older adults are also more vulnerable to loneliness, and I think you kind of spoke a little bit about this during the pandemic, which in turn may lead to depression. So I'd love for you to elaborate on that relationship. Can you speak about the relationship between isolation and depression and why that might be particularly important when thinking about older adults?
Right. Let me refer to a study that we have done. During the first wave of the pandemic in New York, my hospital developed a web page and invited health workers to respond to that web page. And part of that, they had many questions and included the PHQ-9, which is the 9 symptoms of major depression. The intent of that questionnaire was to identify health workers at risk for mental health problems and refer them for services. We took advantage of that and we look at the responses of 1,858 healthcare workers. And they were young and old. They started from age 19, really. So what we have seen is that 45% of healthcare workers younger than age 45, they had symptoms of significant depression, meaning PHQ-9 of 10 and above, and that usually is associated with major depression. The corresponding number in older adults was 27%. So people who were older than 65 years old, 27% of them have symptoms of major depression, as opposed to 45% of the younger population. Now, some of the questions that we asked them is they had to do with concern about finances, fear of exposure, because they were frontliners, and recent exposure, recent exposure to patients. The answer, we found no association between these concerns and development of depression symptoms. So fear of exposure, recent exposure, and finances were not associated with depression. What was associated with depression in the young and in the old workers was social isolation. So in both of them, the correlation was significant. It was at a point of 0.3 to 0.45. Interestingly enough, the very young, meaning younger than 25 years old, and the very old, meaning health workers over than 75 years, 30% of them gave positive responses to the item of suicidal ideation. So to summarize these findings in healthcare workers, social isolation or concerns about social isolation were correlated with depressive symptoms on the one hand, and the very young and the very old were more likely to have suicidal ideation of some level of severity.
Yeah, that's a really interesting study that you highlight. And it kind of points to my next topic, which was when I was reviewing the literature, there was quite a few commentaries discussing providers' concerns about older adults being at risk. And one of those risks were for increased risk of suicide. Some other things that came up were prolonged grief disorder, substance use. So what concerns do you have about the long-term mental health consequences from COVID in the older adult population? Do they align with these?
Certainly. Old people, as the slide shows, are more prone to develop medical complications when exposed to alcohol and substance use disorders. And it is well known and throughout the country that social isolation increased the use of alcohol and substances. Older adults have much higher suicide rates than younger adults, although they have a smaller number of suicide attempts, but they really mean it and they kill themselves. And prolonged grief disorder is something that has been of great importance here because when people mourn, what they do is they try to get assistance from their social network. And the social isolation of COVID has interfered with the natural mourning process. So they're quite likely to develop mourning reactions. Also, there is a lot of losses. More than 500,000 people died in the United States, and they left others behind mourning for them. So finally, another concern is that in old age, we have neuro-COVID. And neuro-COVID is associated with about 30% of people who are infected, they will develop a long haul syndrome. The long haul syndrome usually starts with flu-like symptoms, but then it is characterized with fatigue, body aches, shortness of breath, difficulty concentrating, headache, and loss of taste and smell. Now, in the elderly, if you think about it, this fatigue and the body aches and the shortness of breath and the difficulty concentrating are already added to a compromised medical state. That is, they have arthritic pains, they have fatigue, they're not in good shape, and they have a small cognitive reserve that when it is challenged, it might express itself as disturbances in attention, in concentration, in planning, and in memory.
Yeah, I think those are all really important to highlight because I think right now we're thinking about the immediate consequences that COVID-19 might have on mental health, but we also need to think about moving forward and making sure that we're assessing for some of these other potential concerns that may linger on for quite some time, such as you said, neuro-COVID, or even, assessing for suicidality. Those types of things will be important for providers to be mindful of. And now I know the next topic is kind of also talking about assessment and access to care. COVID certainly has presented many unique challenges for the delivery of mental health care, but also for patients and families to be able to access mental health care. I hate to say that there's positives that have come from this, but there certainly have been some creative solutions that have definitely trickled down from this somewhat unfortunate situation as the pandemic. So Dr. Alexopoulos, I'd love to turn this slide over to you. I think it would be great for the audience to hear about some of the specific modifications that you needed to make during this time with your setting, your clinical setting, the hospital, and how patients handled these adjustments, whether they accepted them.
Sure. Let's go to the next slide, which summarizes some of the challenges that you mentioned. A primary concern of healthcare workers is to protect patients from getting sick. And you work in a hospital where people with mental illness, they come in. I work in a hospital, people with mental illness come in, and they have a high rate of infection. In fact, there's a World Psychiatric study that reviewed 61 million people in the United States by reviewing their health records, and they showed that mentally ill people have 7.6 times more likelihood, higher likelihood to get infected by COVID than non-mentally ill people. So here we have a vulnerable population comes to hospital. Now we have to protect the rest of the patients who don't have COVID. And as you would see on the right, as you look at the slide, at the left side of the slide, there are a number of concerns of the staff, because first you need to protect them from getting infected, and second, you need to address their own mental health needs. So all of the social interactions with patients, psychotherapy, group therapy, or activity therapies, milieu therapy, all of these are affected by trying to protect patients from getting infected in the hospital. So what did we do? We did not know from COVID when the COVID started. So we started groping around for solutions. The first thing that we did, from the 14th of April until the 23rd of May, we tested every patient who came in. And after we tested them, we put them in the rooms to quarantine. So they had to be in the room alone. The nurse would come and give the tray and give the medication at the door, but the patient had to be isolated. We couldn't live with this. So what we did is we developed an approach to communicate with the patients remotely. We purchased many tablets. We gave them to the patients. Information technology service was able to give them passwords and were able to communicate and even set up group meetings. It was so we had group sessions through their tablets, and then when the patients left, we had to change the passwords and reset the system again. Logistically, it took about 2 or 3 weeks to put it together. Then it seemed to work. Our outcomes were not worse. Our psychiatric outcomes were not worse. But during that period of time, we have a 9.6 per 100 nosocomial infections, meaning 0.96 per 100, almost 1%, got infected in the hospital. We then decided to follow the SAMHSA recommendations. And what the SAMHSA recommendation says, it is not sufficient to isolate the patient in the room, but it is to create safe spaces. So we created safe spaces, meaning there was a certain space or a whole unit where all patients were infected by COVID. So they couldn't infect anybody else. And the staff would wear the personal protective equipment. And we had a second space for COVID negative patients and a third space for quarantine patients. So somebody who had exposure, somebody who came from another state. When we created that system, so everybody got tested at the beginning and they would go to the space that they belonged. The infection rate dropped by tenfold immediately. So we went from 0.96 per 100 to 1.2 per 1,000. So 1% per 1,000 as opposed to 1 per 100. So this paper is now in review in psychiatry research. And the number of subjects that it refers to is 1,139. The logistics are very difficult because the spaces had to change depending on how many COVID positive you have and how many quarantined you have. So the logistics requires a lot of coordination, but the outcome was, to my mind, spectacular.
Yeah, that's absolutely amazing. I can't believe the reduction that you had through those. It seems like it was a learning process along the way in terms of modifications that you had to make, which actually makes me wonder, I know some of those are COVID specific in terms of how you're stratifying patients, but the stuff with like the tablets, is that something that you think you'll continue to use in the hospital setting?
We do. Our hospital uses tablets because, and you have to use the tablets even in the COVID negative units because you have no assurance that a COVID negative test on day 0 or on day 1 means that the patient will not convert into a positive by day 4. Now, that's not part of the study, but recently, within the last month, we now test both on day 1 and day 4. And we continue to use the three-space algorithm.
Yeah, because when I initially thought of a lot of these changes, I was thinking, how receptive the older adult population would be to technology and the use of, interventions through telehealth, et cetera. But it seems like, at least in your sample, they were very receptive.
Well, we learned about that as well. At the beginning, we tried to use more complex communication systems, including Zoom. They couldn't handle Zoom. The old adults couldn't handle Zoom. We had 2 or 3 steps. It's simple for somebody who's accustomed to it, but not to them. But they can use FaceTime. So FaceTime ended up being okay, and they use the telephones as well. And we have some restrictions on the telephone. So if a manic patient comes in, for example, a telephone may not be given. So they may communicate with us, or we allow them to communicate with us with FaceTime, but we wouldn't allow them to communicate with a bank and buy the Queensboro Bridge.
Well, that's really cool. It's interesting to hear about the success of those modifications and the stuff that you did within your setting. I'm sure the audience enjoys that as well. I'm sure they had to be creative on the fly similarly. I'd love to end with the discussion around psychiatric medication considerations during COVID-19. A couple of the bullet points there highlight. So the first one, you can see there has been some research that suggests that certain psychiatric medications have been associated with increased risk of COVID-19 infection. I'd also like to make the listeners aware of that second bullet point, that there was a work group that was established and they published evidence-based practical recommendations on the optimal management of psychiatric psychotropic medications in people with COVID-19. But I'd really think it'd be helpful for them to hear from you, Dr. Alexopoulos, if you want to elaborate on, specific psychiatric medication considerations that are important to think about during COVID-19, particularly when it comes to the older adult population.
Right. Clozapine has been one of the medications that has been associated with increased COVID infection. People on clozapine and perhaps other antipsychotic medications had 1.8% higher chance to develop COVID infections. Now, we don't understand this association. It may be that patients who require antipsychotic medicines are more prone to risky behaviors and increased rate of infection. On the drug interaction side, overall, psychiatric medications, they don't have significant interactions with COVID medications. An exception is clozapine, that if patients are treated with dexamethasone, and the standard protocol now is dexamethasone 6 milligrams a day during severe COVID infection, Dexamethasone increases the plasma levels of clozapine. Antipsychotics and benzodiazepines may cause respiratory depression. So if somebody is struggling for air, as the COVID pneumonia patients, you need to be thoughtful of that and try to use this agent sparingly. Antipsychotics, and in particular clozapine, benzodiazepines, and some of the mood stabilizers like carbamazepine and oxcarbazepine may increase the risk of secondary infections in COVID patients. Antipsychotics and antidepressants increase the risk of thromboembolism, and also they increase the risk of bleeding, especially antidepressants. So one needs to be aware of that risk. In patients with neuro-COVID who develop delirium, anticholinergic drugs and sedating drugs and lithium should be avoided. Olanzapine and risperidone, on the other hand, have been found to prevent delirium. So sometimes small doses of these agents may reduce the likelihood of developing delirium in COVID-infected patients. But benzodiazepines increase the incidence of delirium. I also wanted to put a good word for antidepressants. So they don't only do bad things, but antidepressants are anti-inflammatory agents. And in particular, an antidepressant that has sigma-1 receptor agonism was found to reduce the likelihood of clinical deterioration in patients who have been COVID infected. So all in all, antipsychotropic drugs and antidepressants, the rest of antidepressants can be used in patients, but with these provisos that I just mentioned.
Yeah, thank you, Dr. Alexopoulos. I actually just had another question that popped into my head because I've been asked it a few times recently. Are you aware of any information around psychiatric medication use and concerns about the vaccine, like any interactions there?
No, the vaccines do not have interactions with psychotropic agents. Overall, it is important to emphasize that vaccines do not cause COVID. What they do, at least the two vaccines that are available in the United States, they create antibodies against the spike protein of COVID. They have no mechanism that can induce a COVID infection. And that is something, part of the confusion of people who are not proponents of vaccination. It is imperative for people to vaccinate. And the reason is that the only way for the COVID virus to create variants is to enter human body. By vaccinating many people, you reduce the number of bodies that are available to the virus to enter and multiply and create new variants. When the COVID virus is out of the human body, it's a dead molecule, doesn't do anything. So my recommendation is try to tell your patients how important it is to vaccinate, not only for protecting themselves, but protecting the overall community.
Yeah, thank you, Dr. Alexopoulos, because I have been asked that question quite a lot recently, whether there's potential interactions. I'm glad you clarified that and the importance. Well, thank you so much, Dr. Alexopoulos, for the informative commentary. I'm sure the audience found it extremely valuable. I know I learned a lot putting the slides together and hearing about some of your experiences throughout this time. Thank you to the listeners. If you enjoyed this presentation, be sure to check out the other resources that we will have on the mental health across the lifespan series.
Thank you.